Hello, everyone. We discuss the topic of management of atrial fibrillation in primary care today. This is your host, Dr. Rahul Srivastav from A4 Medicine. Atrial fibrillation is not just an ECG diagnosis, it's a long term clinical pathway that requires structured decision making. In primary care, the challenge is not just recognizing AF, but knowing what to do next, how to confirm it, how to prevent stroke safely, how to control symptoms, and when to escalate care. In this session, we will simplify AF into a practical framework aligned with the NICE guideline and focus on RCGP AKT priorities. We will move through step by step through detection, protection, control, and long term review. This section introduces the overall clinical structure used to manage AF safely and consistently in practice. AF management can feel complex because it involves multiple parallel decisions, but in practice, it simplifies into four domains. First, we detect and confirm the diagnosis. Second, we assess stroke and bleeding risk and decide on anticoagulation. Third, we control symptoms using rate or rhythm strategies. And finally, we review the sustained treatment over time. This structure ensures no critical step is missed, and we will come back to this slide once more before we finish this presentation. This section explains why AF is clinically important even when patients are asymptomatic. AF affects around 1 in 50 adults in the United Kingdom, but its importance is not prevalence, it is the consequence. It causes around 1 in 5 strokes. And importantly, AF is often silent. Many patients present only after stroke or heart failure. That is why opportunistic pulse checking matters, even in asymptomatic patients. This section introduces a simple memory framework for AF management used throughout the rest of this presentation. We simplify AF into four steps. As we discussed, detect, protect, control, sustain. AF is not a single decision at diagnosis, it is an ongoing clinical pathway. This section explains how AF is confirmed and why intermittent AF can be easily missed. An irregular pulse is a screening finding, not a diagnosis. A 12 lead ECG is required to confirm AF. But if AF may also be paroxysmal. If symptoms are intermittent and ECG is normal, use ambulatory monitoring. This may include 24-hour tape or event recorder. A normal ECG does not exclude AF. This section explains AF types and clarifies that classification does not determine stroke prevention. AF is classified by duration. Paroxysmal terminates within 7 days. Persistent lasts more than 7 days. Long standing persistent lasts over 12 months. Permanent means no further rhythm control is planned. These categories guide rhythm strategy, not stroke prevention. Anticoagulation is independent of the type of AF. This section explains how stroke prevention and bleeding risk are assessed during two separate tools. Using two separate tools, we also, the first one is called SHAD VAS, which estimates the stroke risk. Orbit estimates the bleeding risk. They're not competing tools, they answer different questions. A high bleeding risk score does not automatically stop anticoagulation. Instead, we modify the risk factors. This section defines when anticoagulation should be offered based on the validated scoring threshold. Offer anticoagulation if SHAD-VAS score is 2 or more. Consider it in men with score 1. Do not offer if no risk factors other than sex. Orbit identifies bleeding risks like hypertension, alcohol, interacting drugs, anemia. Fall risk alone is not a contraindication. This section explains safe DOAC selection and the importance of correct renal dosing. DOACs include apixaban, rivaroxaban, dabigatran, and edoxaban. Choice depends on clinical factors and preference, but dosing must also use the Cockcroft called creatinine clearance, not EGFR. That's why you often see pharmacists mentioning this if you discuss initiation of anticoagulation with them. Incorrect dosing risks under anticoagulation and risk of stroke. This section explains how warfarin quality is assessed and when to consider switching therapy. Warfarin quality is measured by TTR, which is time in the therapeutic range. Target is above 65%. Poor control may reflect adherence, diet, or interactions. These could be corrected first. If control remains poor, switching to a DOAC is appropriate. This section explains first line symptom control in stable AF. Rate control is first line for most stable patients. Options include using beta blockers or diltiazem or verapamil, i.e., calcium channel blockers when beta blockers cannot be used. Digoxin is for sedentary patients or when other agents are unsuitable. The goal is symptom control, not rhythm restoration here. This section highlights a dangerous drug combination that must be avoided. Avoid beta blockers plus verapamil. Both are rate limiting. This can cause severe bradycardia or heart block. If combination therapy is needed, safer options are beta blocker plus digoxin or diltiazem plus digoxin. This section explains when rhythm control is used and its limitations. Rhythm control is used when rate control fails. Options include antiarrhythmic drugs, cardioversion, or ablation. Ablation may need repeat procedures, but successful rhythm control does not remove the need for anticoagulation. This section covers emergency management of unstable AF. First, assess stability. If unstable, shock, syncope, ischemia, immediate cardioversion is needed. Do not delay for anticoagulation. If heart failure is suspected, avoid calcium channel blockers and escalate urgently. This section explains how AF duration changes immediate management strategy. If onset is under 48 hours, rate or rhythm control is acceptable. If over 40 hours or unknown, start with rate control. Cardioversion requires at least 3 weeks anticoagulation if duration is longer or uncertain. This section defines when a specialist input is required. Refer if symptoms persist or AF recurs. Also refer for structural heart disease or suspected pre-excitation. Wolf Parkinson White with AF is a medical emergency requiring specialist input. Pill in the pocket. This section explains a specialist strategy for intermittent AF treatment for selected patients with infrequent AF. Criteria include no structural or ischemic heart disease and stable vitals. Importantly, the first dose must be given under medical supervision with ECG monitoring before home use. This is not routine primary care prescribing. This section explains ongoing monitoring and reassessment in chronic AF care. AF is dynamic. Review annually. Check the shared VS score, orbit, renal function, and INR if on warfarin, as we discussed, to check the TTR. Reassess at age 65 if not anticoagulated. Do not stop anticoagulation just because AF is not detected. So we come back to this deck which we discussed in the beginning, which is brings together the entire AF pathway into final memory framework. Detect, ECG and monitoring. Protect using scores like CHAD, VAS, and ORBIT. Control, rate or rhythm based on stability, and sustain lifelong review. AF pattern does not determine anticoagulation, as we mentioned before. The, so this is how we simplify AF management in primary care for a broad framework which we can employ in day-to-day practice. We are constantly producing these YouTube presentations. Please subscribe to our channel. We are an independent primary care education channel. Please subscribe, share, and thank you for watching.